Hi, good morning. Happy Monday, everybody. We're a couple of minutes early, but eager to get started. And I will turn it over to Dr. Atwater to introduce our kind visiting Grand Round speaker this morning.
Hey y'all, can you hear me? All right, sweet. So it is my distinct pleasure to introduce Amit Jain. He is coming to us from Johns Hopkins in Baltimore. I had the pleasure and privilege of training with him. He's from Portland. After doing his bioengineering degree from Berkeley, he went to Hopkins for med school, where he ended up staying for residency. And he went to Emory for spine fellowship, after which he was recruited back to Hopkins. It sounds very linear, but he had plans to go to Rush, and Hopkins ended up winning him back. He is a prolific researcher with I think it said somewhere over 120 publications, which I'm sure by now is many more than that. But basically, he had more publications than most of the professors as a resident, or most of the faculty as a resident, which just tells you a lot about him. Extremely uh, uh, um, uh, active research mind. So we're very lucky to be able to hear from him today. On a personal note, he is one of my best friends, and you can either thank him or curse him for me ending up here, because Portland was never on my radar until my husband and I came out here for his wedding in 2016, 2017. Anyway, so that was how we ended up seeing Portland for the first time. We're like, this place is kind of awesome. So thanks, Amit. It's been great ending up at OHSU, and I have you to thank for that in part. With that, I will turn it over to my good friend, Dr. Amit Jain.
Thank you so much, Laura, for the kind words. Let me share my screen. I just want to make sure everybody can see the PowerPoint slides.
I'm gonna try logging out in case it doesn't think I logged out or stopped sharing.
Okay.
The joys of technology. It looks like it's trying to load. Maybe it's just taking a couple extra minutes this morning. Take your time.
Okay, sorry about that. Let's see. Okay, maybe let me try just logging out and logging back in. Just 1 minute. Sorry about that.
Take your time.
Great, there it is. Awesome. Thank you. Just unmute for us.
Great. Thank you, everyone, for having me on your Monday morning. The goal of this talk is to talk about the impact of the pandemic on non-COVID healthcare. I have some disclosures, none of which are relevant for this talk, including some NIH funding and some other private funding sources. I would like to thank my dear friend, Dr. Laura Atwater, for inviting me. Laura has been a wonderful colleague as well as one of my best friends over the last many years I've known her. She's really one of the best people you can get to know, and really you're very lucky to have her back in Portland. And we wish we could keep her here in Baltimore with us longer. The sobering facts are that the pandemic has resulted in tremendous morbidity and mortality across the world. In the United States, we have had over 500,000 deaths, and it's really affected every corner of our country. Nobody has been immune from this. And unfortunately, in addition to the direct impact on patients' lives, it also had a ripple effect in many aspects of healthcare, including delays in routine and preventative care, as well as cancellation of many non-urgent surgeries and procedures. Here's an example of a 15-year-old boy who had scoliosis, who I was supposed to take care of and do his surgery last summer, but it was delayed by several months because we weren't doing elective procedures at that time. An example of a 14-year-old girl who had Sherman's disease. I was going to operate on her last summer as well, but again, she was delayed by over 4 to 6 months because we weren't doing elective surgeries because we were at the peak of the pandemic. Here is a 30-year-old who had a T2 body giant cell tumor who required an en bloc spondylectomy with an anterior posterior approach. And this patient had a malignant or a pre-malignant lesion, but certainly we were concerned about doing her surgery at the time when there were no ICU beds available. And then here is another one, a 62-year-old with lumbar sagittal deformity who required a 3-column reconstruction and required major spinal realignment. And again, no ICU beds were available, so her surgery was delayed by several months. At some points, the reason patients didn't come to the hospital was their own fear, fear of the virus, fear of social and financial instability, fear of where they're going to go after the hospitalization post-discharge. And at other times, they couldn't come to the hospital because we weren't providing the services they required, because we were simply closed. We didn't have the capacity to take care of them because we were overwhelmed by coronavirus or other sequelae of that. So the goal of our talk today is to really explore the impact of the pandemic on treatment for non-COVID conditions, access to and disparities in healthcare, the economics and business of health, and specifically with a viewpoint of orthopedics and spine care. So our agenda today, we're going to talk about ambulatory care, post-acute care, hospital care, and then access revenue and mitigation strategies. So some of the stories started to become clear early on in the pandemic last year in 2020 around March time. Here is data from Frisia Client, which is a network of over 50,000 providers with over 50 million outpatient visits per year. And as you can see, once the pandemic hit, starting around March of 2020, there was a pretty significant amount of decline in outpatient visits, almost 70, 80% decline by the end of March, and a little bit of a rebound by April. If you track this forward and kind of look at it from a service line perspective, depending on the service line you look at, service lines like rheumatology all the way to ophthalmology, there was pretty precipitous drop in all service lines. We in orthopedics kind of fell somewhere in the middle. Depending on the week you surveyed, either about a 60% drop or around May, maybe about 32 or 33% drop. By June, we were starting to rebound as a nation, about 13% down in our volumes compared to the year prior, but still not quite caught up yet. Unfortunately, as you can imagine, if you're down for 3 consecutive months in a row in terms of your outpatient access and your clinic volume, that creates a cumulative deficit, and that's exactly what happened. In the field of orthopedics, this resulted in a cumulative deficit between March and June of 2020 to about 35%. That means we were a third of the visits down that we would have otherwise completed. Now, fast forward down to the fall time, so around October time. So if you look at the data for the fall, what we found is that orthopedics as a specialty was still down about 4%, which is, we don't think it's too much. But if you add it all up over the course of the year, if you add it up from March, April, May, June, July, all the way and fast forward, the area under the curve represents the cumulative changes in visits. So visits that should have taken place in the outpatient setting but never did take place. And as you can imagine, this would result in a cumulative deficit, which would certainly affect both our patients as well as our practices. So the key message thus far is that there was a significant decline in ambulatory care, in other words, outpatient care, especially at the first peak of the pandemic. And this, there was a rebound from this, but overall, there was a net cumulative deficit in outpatient visits through most of 2020. What about hospital-based care? Well, around the peak of the pandemic last summer, people started noticing that there was this new phenomena of patients who were disappearing from the hospitals. Patients with heart attacks, strokes, and even appendicitis started to vanish from the hospitals. So what was going on? Well, some authors started to look at this. One of the interesting studies that came out of this was by Baum et al. They looked at utilization of Veteran Affairs hospitals for emergent medical conditions. So things that you don't think as elective, things that we know are medical in nature, and therefore patients have to be in the hospital. So things like strokes, MI, heart failure, COPD, pneumonia. And what they found is that the blue line represents the year prior, and then the orange line represents 2020. So in 2020, there was a pretty significant decline, depending on the week that this study looked at. So around April time, for example, between patients who were admitted to the hospital for these routine medical conditions versus in 2019 versus 2020. So almost half of these patients who should have been in the hospital never arrived to the hospital for one reason or another. So a net conclusion from this study was that there was a 42% reduction in VA admissions for medical diagnoses. Now, looking at STEMI activations, which are when you activate the heart attack team and take someone for a PCI. Interestingly enough, this one study looked at 9 major high-volume STEMI centers and found that by March of 2020, there was almost number of activations were cut in half. So in other words, a lot of patients who were having heart attacks were not coming to the hospital, and STEMI was not being activated. The question, though, is what happened to total admissions, and did COVID affect the number of total admissions? So Berkmeyer et al. Looked at this, and what they found is that, so the blue line is the 2019 total admissions, the orange line is the 2020 total admissions, and the red line is 2020 non-COVID admissions, so admissions that could not be attributed to COVID or COVID-related sequelae. So in other words, compared to the blue line, the difference between the blue and the red line is the overall drop in admissions in hospitals in April, May, June, July, etc. So pretty significant decline. And we're talking again about conditions like pneumonia, COPD, sepsis, UTI, acute STEMI, all of which saw a pretty significant decline from 20 to 40% or so. So the question becomes, how does this impact access mortality for non-COVID conditions? How do our country fare in terms of patients who have non-COVID type medical problems, and how did they do? And Stephen Wolf et al. Looked at this, and what they found in a JAMA study is that from March 2020 to January 2021, there was a net 23% increase in all-cause mortality in the United States. That means almost a quarter of our population had an excess mortality rate, so 23% based compared to what the normal mortality rate would have been had COVID not occurred for non-COVID conditions. So pretty sobering numbers. And interestingly enough, they also mapped this based on geographic infection surge. And what they found is that depending on the states that were being hit at a given time, so for example, states like New York and Pennsylvania, New Jersey, et cetera, that got hit earlier during the pandemic, versus states like Arizona, et cetera, that got hit around summertime, versus some of the mountain states that got hit later in the fall. Depending on the timing of when COVID hit those states, the mortality for non-COVID conditions in those states surged around that time. So in other words, patients were not coming to the hospital because of fear of COVID, because those states were being affected, or alternatively, those hospitals didn't have the capacity to provide care for non-COVID conditions at those times. As you can imagine, this would certainly affect social and health inequalities, and certainly researchers found that these inequalities only got worse with COVID. They already existed prior to COVID, but because of the pandemic, they certainly took a turn for the worse. So this particular study from the Kaiser Family Foundation looked at overall hospitalizations in African Americans and Hispanics compared to Caucasian patients. And what they found is that the number of cases of COVID, as well as the hospitalizations associated with COVID, were integer multiples of in Caucasian patients. So certainly these minority and poor communities were disproportionately affected. Another study by Berkmeyer and Health Affairs looked at trying to quantify the exact mortality increases in the minority and poor communities. And what they found is that there was almost a 2.5 to 3% increase beyond the increase that COVID resulted in minority and poor communities. So in other words, they were really disproportionately affected as a result of this problem. And certainly there are a variety of social determinants of health that affect this, that include economic stability, social and community context, neighborhood environments, access to healthcare and education, and it's a multifactorial problem, but the end result is that these communities were disproportionately affected. So the key messages thus far is that patients stayed away from hospitals, partly because of lack of access and partly because of their fear of coming to the hospital. And these are not just for elective issues, but also non-elective things that really you would think one would be in the hospital for. And this resulted in excess morbidity and mortality for many non-COVID conditions. In fact, almost a 25% increase in all-cause mortality in 2020 for the US. And minority and poor communities were really disproportionately affected. What about musculoskeletal care? What about the area that we are most interested in? So Whaley et al. Looked at this, and what they did is they segmented patients based on different types of service utilization. So for example, looking at preventative care, what they found is that as a result of the pandemic early on in 2020, in March and April, there was a pretty precipitous decline in preventative care. So colonoscopies, mammograms, hemoglobin A1C, vaccines. In general, people didn't utilize them as much. Non-elective care certainly got hit as well. We presented some of the data about that, about angioplasties. And then interestingly enough, even chemo took a small decline. L&D obviously did not because babies happen when they happen. And then elective care certainly took a huge decline as a result of the pandemic. So musculoskeletal surgery fell in almost half, and cataract surgery certainly took a pretty big dip in March and April of 2020. Looking at service line volume loss, a survey of 228 hospitals, 51 health systems, 65 million people was done that looked at the weeks of 2019 in March and April, comparing them to 2020. And not surprisingly, the biggest service line hits were in ophthalmology, spine, GYN, orthopedics, and ENT. So spine and orthopedics making two of our important service lines. And here's the data for the state of Maryland. This is a study we did. We looked at what happened in the state of Maryland in terms of elective surgical utilization. And what we found is that depending on the quarter, in Q1, there was just a small hit in overall elective surgical utilization compared to 2019. In Q2 of 2019 versus 2020, there was almost a 56% drop in overall elective surgical utilization. And in Q3, there was about a 16% drop. And the largest declines happened in orthopedics, urology, and plastic surgery. So pretty interesting. By Q4, I think there was a small rebound, but we still weren't caught up to the 2019 numbers. McKinsey et al. Looked at this phenomena as well. They surveyed 25 large US hospital systems, and these are systems that have over 1,200 beds each. So we're talking about fairly large systems. On average, what they found is that the hospital systems saw a 35% decline in OR volumes. And this really trailed off for most of the year, all the way till the end of 2020. Obviously, the biggest declines being in April and May, around 60% and 40%. When in a lot of states, there were elective surgical bans. And then even afterwards, there was a rebound compared to April and May, but certainly the overall volume remained lower than in 2019 baseline. They concluded that the largest surgical volume declines were in orthopedic surgery, ENT, and plastic surgery. They looked at barriers for why this was, what was causing hospitals to not be able to act at 100% capacity and be able to perform at pre-COVID levels. And what they found is that the biggest sources of shortages were workforce shortages. So there just simply wasn't enough nursing staff available because they were redeployed or just weren't available. Inpatient bed availability, and then OR room capacity, as some ORs were being turned into ICUs. So the conclusion from the McKinsey report was that the combination of surgical backlog paired with reduced effective hospital capacity would impact both providers and patients for years to come. So they essentially estimated that there would be some kind of a backlog. Now, whether or not this would last years is an interesting topic, and I think something that merits further conversation. We tried to model this for orthopedic surgery. We looked at modeling ramp up and backlog in elective orthopedic surgery. One way to think about this is looking at prior epidemics and see how the world recovered from those. So if you look at the 1958 Asian flu or the 1918 Spanish flu, what we find is that the recovery, even after the pandemic was starting to die down, took time. It took a couple of years. In the case of the Asian flu, about 1.5 years. In the case of the Spanish flu, almost 2 years of the ramp-up period. In other words, the ramp-up was not 0 to 100 instantaneously, but took time. It was a sigmoidal ramp-up. So using that insight, we tried to do a modeling study where we modeled elective total joints as well as elective spinal fusions that were done in the US. We assumed that you can't go from 0 to 100 instantly, and instead ramp up would be sigmoidal and would be follow a Gompertz function, which is basically a sigmoidal curve. And the way we did this is we use a technique called a Monte Carlo simulation of a Gompertz function. So the idea is that if you repetitively sample a probability distribution, you're going to become closer and closer to the truth over time. And what our results were the following. So prior to the pandemic, so pre-SARS-CoV-2, we were chugging along as a nation, doing about 170,000 elective arthroplasties or spinal fusions per month. So pretty significant amount of number. As a result of the pandemic, these numbers dropped pretty significantly all the way by March, April, and May, down to just a fraction of the volume that was being performed pre-pandemic. And then depending on the assumption you use in terms of your recovery modeling, optimistic, ambivalent, or pessimistic, it would take somewhere between 6 to 9 to 12 months to kind of start ramping up. And then after that, it would take somewhere between 12, 16, and 20 months to kind of ramp up to pre-pandemic 90% volume. And this is what the final result was, that assuming ramp up started in June 2020, under optimistic conditions, so assuming that the disease would be controlled in a good manner, the population would once again be able to access the health systems, et cetera. Under optimistic conditions, it would take 7 months to get back to pre-pandemic volumes, ambivalent 12 months, and pessimistic 16 months. And interestingly enough, our experience at our institution has been, we have kind of fallen somewhere in the ambivalent range in terms of our ramp up and our ability to recover. So as you can imagine, if you're not performing at 100% for all of those months, then that would result in a backlog. And really there are two types of backlog. There's a fixed backlog, which are cases that are not being done during the suspensions. So these were cases that we just didn't do from March to May of 2020. So that added up to about 500,000 elective orthopedic cases across the nation. And then there's a dynamic backlog, which are cases that are not being done while you're not back to 100% production capacity. So you're not operating as efficiently as you possibly could, or as you were at least pre-pandemic. And this continues until the ramp up is complete and is certainly affected by future suspensions. So pictorially, the same concept basically is the following. So you have a fixed backlog of about 500,000 cases, and this dynamic backlog that continues over time till you're still ramping up and not back to 100%. The end result is that with the fixed and dynamic backlog, there can be over 1 million cases for elective arthroplasties and spinal fusions that were backlogged, at least based on our analysis. And certainly future suspensions or slowdowns would alter this number as well. We were fortunate to publish this in JBJS. And then our conclusion was really orthopedic surgery was one of the worst field hits by surgical and procedural suspensions, and then likely created a large backlog of over 1 million elective arthroplasties and spinal surgeries, and it may really take us years to catch up. Now, the interesting thing is that, it's not just access to care, it's also patients' ability to access care because of lack of insurance and employment. And this was an interesting phenomenon that occurred as a result of the pandemic. So unfortunately, there was a huge loss in jobs that spurred because of a lot of small businesses, especially in the retail sector, a lot of job losses that led to record unemployment. It's almost 13% unemployment. And as you can imagine, a lot of patients are dependent on their jobs for health insurance. So if you don't have a job, you may lose your health insurance, which can certainly result in a problem and inability to access healthcare. So a study by Kaiser Family Foundation looked at this, and what they found is that overall, as a result of patients who were newly uninsured due to employer-sponsored insurance loss, as a result of the pandemic, was almost 26 million patients. So 26 million patients who previously had insurance but now lost their job and didn't qualify for another program, basically were uninsured now. And interestingly enough, as a result of this, there was record increases in enrollment in Medicaid and CHIP in 2020. In fact, this has been the highest Medicaid enrollment in the history of Medicaid. So prior to the pandemic, the increase in Medicaid enrollment was generally about 0.3 to 0.4 million patients per month. So that was kind of early March. But by June, July, August, September, as you can see, 6 million new patients were being added to Medicaid per month. So 10% increases compared to prior. So pretty significant amount of patients going into Medicaid and government-sponsored programs. Unfortunately, some of these abilities to enroll in Medicaid came from Obamacare or ACA, and that really depended on this, whether or not the states adopted this, and not all states expanded Medicaid expansion. And as a result, some of the states that did not adopt these measures resulted in persistent coverage gaps and a high percentage of patients who were uninsured because of COVID and continue to remain uninsured. So the key messages are: unemployment spurred large insurance losses. There were large shifts in insurance from employer-sponsored to state or federal programs for low-income or newly unemployed patients. And certainly, as you can imagine, more uninsured patients means less ability to access care or seek care. Next, I would like to turn a little bit and talk about revenue, practice and hospital revenues, and how the pandemic affected that. Unfortunately, one of the victims of the pandemic were small or solo practices. So really, health systems weren't affected to such a large degree, but a lot of small providers and people who were in solo practice were really affected. Interestingly, at the same time, the other side of the coin is the health insurance companies. So they actually saw record profits. So if you happen to buy a stock in Anthem, United Healthcare, or Humana last year, they were actually really good years because they were record profits because premiums were being paid in, but they didn't have their high costs because healthcare was not being utilized. So the end result of the end result of the pandemic was that overall, there was about a $15 billion revenue loss for primary care practices because of patients not seeking primary care and visiting primary care physicians. The AMA did a survey looking at the losses over the course of the year, and what they found is that by July and August, almost 81% of physicians still said that their revenue was lower than pre-pandemic, and the net revenue drop was about a 33% down, so about a third down. So as you can imagine, this would certainly really affect the physician practices. In addition to that, the hospitals took a pretty big hit. Projected hospital losses for 2020, according to the American Hospital Association, was almost $320 billion. So pretty significant overall losses from a hospital perspective. And this is interestingly, despite of receiving the CARES Act money. Now, not all hospitals suffered losses. Some actually made money and did well because of CARES Act money. But this was the overall interesting, I think, summary slide. So this is data from Kaufman Hall Analytics. And what they look at is they look at margin, which basically means profit, volume, and then revenue. Revenue means how much money is coming in. So the gross inpatient revenue was 4% down in the first half of 2020, and the gross outpatient revenue was about 10% down in the first half of 2020. Now, what that meant was that with CARES Act money, margin is revenue minus costs. So with CARES Act money, the margin was only 2.3% down, but still a lot of the hospitals were in the red. And many hospital systems generally run in about a 2 to 3% margin to begin with. So for them, losing this profit is a pretty big deal. Interestingly, not all states and not all hospitals had this problem. Maryland is a unique state. Maryland has what we call an all-payer system, where there's a central body called the HSCRC that sets prices. And interestingly enough, the central body has the ability to change prices in order to respond to calamities like this. So during COVID, it actually allowed hospitals to increase their prices by 10 to 20%. And as a result, the Maryland hospitals actually saw a pretty significant amount of increased revenue that really buffered their losses. We were lucky to be able to present this work in JAMA and publish it in JAMA. And basically what we found is that the orange line represents what the actual revenues were in Maryland hospitals, on the left being inpatient, on the right being outpatient. The dotted orange is what the revenues would have been had the state not stepped in and the HSCRC not done price adjustments. And the difference between these two orange lines, so the area between the curve, between those two orange lines, is the net buffering that was provided. And as you can imagine, this added up to almost $1 billion in the state of Maryland. So pretty significant. So the key message is that providers and hospitals lost significant revenue, and many had negative operating margins or losses in 2020 across the country. Not all hospitals had that fate, and some such as those in the state of Maryland, actually fared pretty well due to unique financial models that basically cost shifted some of the losses from the payer, some of the losses to the payers, essentially. And finally, I would like to talk a little bit about mitigation strategies. So far, I've presented a lot of data that basically tries to support the thesis that COVID resulted in huge volume losses that hurt our patients in terms of access and also affected our revenues for both practices and hospitals. So the question is, what can be done about this, and how do we rebuild going forward? We were lucky to present some of our thoughts in a Harvard Business Review article recently on how hospitals can get back on track. And basic tenets are the following. So one is you have to really preserve access to care. And there's lots of different ways to do that. So patients already have a lot of fear of accessing health services. And one way to keep patients engaged and reduce their fear as well as provide them the care they need is through telemedicine. And this is a telemedicine volume for our institution. So for specifically Department of Orthopaedics. So this is how many telemedicine visits we are doing per month last year. So we're doing a pretty significant amount of telemedicine visits. This right here is a map of us compared to all the other surgical services at Hopkins. So in orthopedics, we really adopted this and kind of went all in with telemedicine. Another way to do that is transition to outpatient surgery. So we know hospitals are occupied and we know hospitals may be inaccessible for periods of time because of the pandemic. But what about shifting some of our cases to outpatient sites? And we really kind of spent a lot of money recently to develop a major outpatient center where we can do ambulatory surgical care and essentially provide that in a very safe and effective manner. And a recent survey by AHRQ essentially found that 86% of ASCs were rated either excellent or very good in terms of their safety rating. And many of these are multi-specialty, so they can actually accommodate multiple things, orthopedics, ENT, plastic surgery, and so on. And many of them are actually multi-room. So it's a good opportunity to move, especially the care that doesn't need to be at the hospital, to an outpatient setting. Then the next idea is to utilize your OR space better. So OR is a valuable commodity. So why do we shut it down on Saturdays and Sundays? Why not increase daily run times? So instead of having 8-hour blocks, why not having 12-hour blocks and so on? And the idea is not that every surgeon or every surgical team member has to work 7 days a week or has to work on the weekends, but maybe for someone who wants to work on a Saturday and wants to take Monday and Tuesday off, they should have the flexibility to do so, especially given that a lot of the country has moved into flex work, so medicine should move in a similar manner. And then the next point is dedicated teams improve efficiency. Now, this is a point that we all know and love and is near and dear to our heart in orthopedics. But unfortunately, from a health system perspective, sometimes this insight gets lost because they think cross-training a nursing person or a surgical assist into multiple specialties is better. But really, dedicated teams improve efficiency, and it's something that I think COVID really highlighted, that when we are able to do things in a team manner, we are able to do it better. And then finally, consistent, transparent, and bias-aware algorithms for surgical prioritization. Now, most hospitals in the country had some kind of a ranking algorithm or some kind of a triage algorithm to decide which urgent or emergent cases ought to go first. So certain cases take priority, but on the elective side of things, no hospitals really had this. So really spending and being thoughtful about this. So, what's elective? How do we decide who gets to go first, especially when you have a big backlog of cases in each service line? What type of system do you use? Do you use a reserve system where you allocate for certain protected classes? Do you use a point system where you make a rank list based on total points? And how do we kind of go about figuring out whose cases get to go and which patients ought to be prioritized? So really spending time to think about a consistent and transparent way to do this, I think, is important, and one of the things that COVID highlighted. We were able to think about this topic and present some of our thoughts, and we argue that a multi-criterion decision analysis, where you look at multiple values simultaneously, is key to success, but certainly there are other ideas as well. So in conclusion, the pandemic resulted in huge unanticipated damages and really affected healthcare at large. So there were huge declines in volume for non-COVID conditions. There was excess morbidity and mortality, in fact, 25% excess mortality for the US, loss of practice and hospital revenue. There were macroeconomic shifts with loss in insurance and access, And certainly minority and poor communities were disproportionately affected. We in orthopedics had a huge impact in terms of losses that we saw, as well as, unfortunately, development of a potential elective surgical backlog. So these are patients who should have been operated on or needed the care, but unfortunately weren't able to access the health system, or for fear of accessing the health system, didn't decide to seek the care they needed. And I'll stop there and open up for discussion.
Thank you so much for joining us in this incredible body of evidence. I feel like a lot of these topics that we've been talking about as a department and just in the operating rooms and clinics for this whole last year, and you went out and got us a lot of great information and detail on the actual numbers. So, I guess my first question is, how are things in Baltimore now? What is your department doing? How's your practice look at this point?
Yeah, thank you, Dr. Grindle. I think it's really interesting. People's attitudes about how much of a hit we were going to take continue to change all through the pandemic. So when it first came out, everybody thought, "Oh yeah, this is just going to be like the flu, and it's going to kind of go away." And then it started to become more and more real, where we had an elective surgical shutdown, and people said, "Wow, this is really incredible, and what do we do now?" And then around fall time, we thought, well, maybe things are back to normal because we can go back to the races and start ramping up and start, in fact, doing 110% capacity that we were doing previously. But if you add up the numbers, all in all, the reality is, in 2020, the number of cases we did were much lower than in 2019. And if you add it all up, the reality is a lot of patients who would have otherwise sought care ended up not coming to the health system. And now one could argue that some of this is care that is avoidable, so care that didn't need to take place in the first place. So for example, there's overutilization in spine care and arthroplasty, and some of this is care that didn't need to take place. But even then, if you take some of that out, there's a pretty significant backlog that's out there where for years to come, we're going to have to deal with that. And certainly the disease progresses. Your certain question was about my particular practice. My practice was pretty much shut down last spring. In the fall, I was busiest ever. I mean, I think there was 1 month where I did 45 spine cases. Certainly once it started hitting February time, it kind of evened out and became regular again. So we'll see what the future holds.
Thank you so much for all of this. As I agree with Dr. Gundel, really, really amazing data. We in Oregon expected to see a big shift of insured and uninsured, and that probably has not taken as much effect as we predicted. Most of our insured patients and uninsured looked about the same. Some of that has to do with the peculiarities of Oregon as a state and the vestiges of the old Oregon health plan. But I think all the other stuff we see similar. And I guess maybe my question to you is, you sort of presented this very, very long tail of not getting back to 100%, which is something we see. Is there a way around that? I mean, what do we do now? Because I think we see that as a hospital. I was just finished on call this weekend, and we're full to the gills of trauma and tumor and stuff that can't go anywhere else and has to get done. And how do we get the elective stuff back through? Because we're still not, we're stuck at 90% as you predict.
Yeah, no, thank you, Dr. Freeth. I think it's not a simple problem. It requires the multifactorial type of approach. One of the strategies I think is important is to really value innovative ways to move care out of the hospital into outpatient or ambulatory settings. Obviously, that has to be done in a safe manner. But I think this is really an opportunity for us to rethink some of our care pathways and move things like arthroplasty for the appropriately selected patient. A lot of spine surgery like microdiscectomies and ACDFs for the appropriately selected patient to the outpatient space where it's safe and effective, and patients don't have to come to the hospital for that. That's good for the patient, it's good for us, and it's really a nice opportunity. I think the other way to think about this is we have to, in healthcare, we really have this tribalism mentality where it's orthopedics versus cardiac surgery versus, it's everybody versus each other, right? Because if I get a second room, that means somebody else is losing a second room. And I think we have to think more creatively, and beyond that, we have to kind of figure out how do we work together to make it efficient for everyone. So maybe certain types of cases ought to be done later in the week as opposed to earlier in the week. And what I mean by that is, for example, if I'm going to do a L4-5 TLIF and do it in an open approach, maybe that's a better case for a Friday, so the patient can recover Saturday, Sunday, and get out of there by Monday, as opposed to Monday where they're clogging is not the right word, but where they're consuming the inpatient floor or bed for a major portion of the week. So I think kind of having some strategic thinking about when cases ought to be done and better demand matching, I think that those are important aspects of this.
I have a question and a comment. Great to see you. I remember interviewing you, and I'm kind of sorry that you didn't come and join us. I remember ranking you very high, but obviously you've done all the right things, and I'm very proud of what you have accomplished. So it's great to see you again. One of the problems that I think we face at OHSU is we were already running at essentially 100% capacity in the hospital. So even though, yes, during the pandemic, we slowed down and all that, we really didn't have any beds then. And we had the idea of we were already doing a construction for about 100 and something like 20 new beds, which because of the essentially finances that they had to shut it down. So I'm sure it'll come on board, but it's going to take probably another 3 to 5 more years before all the beds come on board. So 2 questions are, number one, you can run a margin of 3%, 5%, whatever. That may not be enough to build new facilities. Turns out OHSU was running about 11% EBITDA, which is like unheard of, but that's what they were doing before the pandemic. So the concern really is, is there enough revenue generated to invest in facilities, which is more than just running the operation. Number 2 is at Hopkins, did you guys have enough capacity to essentially ramp in because the hospital has some capacity already, or are you using other partner hospitals? I know you guys have some partner hospitals, and has there been shift toward work in those facilities to accommodate for capacity issues? A lot of questions, but I hope you can answer.
Yeah, thank you, Dr. Yu, and great seeing you. And I just wanted to, just for the residents and any trainees, when I was a medical student, I only did one sub-internship, away sub-internship. I probably should have done more, but I did one at OHSU, and I got to spend a month with Dr. Yu as part of it. And I remember you were a Jedi master in the OR, and I really looked up to that. So the other thing you taught me was a concept of Quo-Vadis. Maybe I'm mispronouncing it, Quo-Vadis. And I remember it because it left a mark on me, and I always think about that. So thank you. And for the residents who don't know what that means, you should look it up. To answer your questions, I think there are 2 aspects of this. One is we frequently think of the academic health system as a mothership hospital with a bunch of other kind of satellite hospitals that are not as good. But I think we really have to start changing the narrative on that. And we have to think of the health system as a true integrated system where work is done at the appropriate site, depending on what is, and utilizes that site's strengths. So I think one of the ways we have done that here is instead of doing total joints at our main mothership, we have basically made one of our community hospitals, which is part of the health system, the place of the center of excellence for total joints. And we do all our joints there and really utilize that. And that was one of the places that didn't really take a big hit as a result of the pandemic, because the number of COVID patients there were lower and so on and so forth. So we really have to think about as an integrated practice where we can shift cases to other sites. And maybe cases like oncology cannot be shifted out of the mothership because you need the multidisciplinary team approach, et cetera. But some of the other cases which are more elective in nature can be shifted to other sites. So I think we have to do that. And really one of the ways we utilize our system. Interestingly enough, the Johns Hopkins Hospital itself was not the worst one that was hit by the pandemic, but one of our community hospitals was, which was completely overwhelmed. And part of that was because of its strategic location and kind of the community spread. And I think when that happens, you have to then figure out what are you going to do with patients who would have otherwise received elective care in that setting. One of the ways we did that is we essentially converted that hospital to a completely medical facility, and then over time started ramping back up. I think one thing that helped us in Maryland is the state was very involved, and as I mentioned earlier, the state allowed price increases. So Maryland hospitals actually didn't lose any money. So if you look at 2020, the hospitals actually made even, in fact, if anything, actually made a little bit of money once you account for the CARES Act dollars. So I think it's unique to each state. Certainly making new facilities cost a lot of money. And I don't think the solution is necessarily increase capacity in that manner in the short run. But in the long run, that is probably a good strategy. In the short run, I think we just have to reduce inefficiencies and focus on ways where we can better serve the kind of patients that can be served. So I guess I didn't exactly answer your question, but I think the bottom line is I don't think the idea of having to build new facilities overnight is really realistic, as you correctly pointed out. I think it's just it's wishful thinking, but it does have to be the part of the strategic plan in the long run.
Do you have residents in the outlying hospitals? Because I think it's nice to have the facilities that other hospitals that people can work in and or that, but as an academic, I mean, to me, not having residents, which gives me great amount of joy. I mean, to go and work at a place that doesn't have that, I'm not particularly interested. You know what I mean?
Absolutely, yeah. So one of the ways we have done that is we have 5 hospitals as part of our health system, 4 of which are in the Maryland area, and we have made it a point to have residents on each of our orthopedic services there. And the residents really enjoy it too, because not everybody wants to go into academics. A lot of people want to spend time in the community setting, and it's great because it shows you the other side of the coin.
Thank you.
Well, thanks again, Dr. Jain, for joining us. I think this is just fantastic, and congrats on your many, many publications and accomplishments. And thank you for your time and making us smart here this morning. I really appreciate it. Any other last questions from anybody? All right. Well, it's great to have a Portlander back here, at least virtually, and hopefully we'll get you to come in person when we can do such things again. Okay.
Thank you so much. Thanks, everyone.
Take care.
Yeah.
Thank you.